Our last speaker is Dr. Audrey Rostov, who will be speaking to us on small aperture intraocular lenses for complex corneas.
Thank you, and thank you for inviting me. I will be continuing where Judd left off. My financial disclosures: I am a consultant with Bausch & Lomb. We've already been through the small aperture optics and what the lens looks like with that filter zone there, so I will just go through there. Complex case selection, it is my go-to lens. The small aperture lens is my go-to for RK, and I actually do use it bilaterally in patients, not just unilaterally. Also select case of corneal scars as well as for keratoconus. First case is a 64-year-old woman who had a 16-cut RK. Here is her pentacam, as you can see here, with the flattening and the higher order aberrations, and this is her refraction. This is her left eye. Every single patient I do cataract surgery on, whether they're a premium IOL or irregular cornea or whatever it is, I do get an OCT of the retina. And even though I'm not a retinal specialist, I could tell you that the MAC OCT of the right eye is abnormal, and there is a lamellar hole there. That's about the extent of my retina knowledge. Diagnostics, when we get biometry, I aim for about a -1 to -1.25 for post-RK patients. This is with a small aperture lens and also for corneal scars. For keratoconus, I do a little bit more myopia in the -150 to -2 range. I always get tomography and again the OCT of the macula. I really want to temper patient expectations and emphasize that the pre-existing pathology will ultimately limit their visual acuity, and the goal is to improve but not perfect. For this patient with the 16-cut RK, the right eye, I chose a toric lens because of that macular pathology, and you could see here actually that I used scleral incisions because of the multi-cut RK. Scleral incision, I'm still doing my biaxial cataract surgery, but scleral incision is going to be better than going through where you have your RK incisions. For the left eye in this patient, I chose the small aperture IOL. You could see what the post-op photo looks like, and she did quite well. Case 2, we have an RK patient, a 74-year-old gentleman with 10-cut RK this time, and here you could see this is the surgery. I measured and saw that actually I could, in fact, go ahead and get the keratome in between the incisions, and so chose to go through clear cornea. Again, I do biaxial surgery. There's the cleanup. I like what Joe suggested about doing the other IOL cartridge. I've just been using what Bausch & Lomb supplies. It is very, very slow unfolding. You need a 3.2 incision, and so you do need a slightly larger incision there. It unfolds slowly, and the main thing is that after it's unfolded and you manipulate the lens, you need to avoid that filter zone. That is that dark area that gives the pinhole optics. So you actually need to be sure that you are avoiding the pinhole zone. Surgical technique, a few pearls here. I have a very low threshold for placing sutures in the cornea, in the incision, whether it's scleral or it's a clear corneal incision. If the corneal scar or keratoconus patient, clear corneal incisions are fine. You have to measure if you're doing an RK patient, and again, avoid the filter zone. This patient's post-op vision with a 10-cut RK was 20/25, and that's uncorrected. Another case, a 56-year-old with a corneal scar, and again, you could see the irregular tomography there, the irregular astigmatism. And here are some results. For his right eye, which was his unaffected eye, I chose an EDOF lens. I think I put a Vivity lens in there, and you could see that there was definite improvement in both post-op for both the EDOF, the normal right eye, as well as for the small aperture IOL. Again, for this patient, I chose slightly more myopia and also wanted to emphasize that the goal is to improve but not perfect. Lastly, we have a 67-year-old woman with keratoconus, as we've been discussing, and here's her tomography. This was her pre- and post-op vision, and again, I went for more myopia. As Sonal discussed, we like more myopia for these keratoconus patients. They're used to being myopes, and so therefore you want to leave them with some myopia as well. Patients with PK, post-PK, I'm a big toric IOL user in post-PK patients, and I do femtosecond laser relaxing incisions at about 7 millimeters at the time of the surgery, and find that there's a synergistic effect. You can also use a pinhole lens here. I have not done that yet, tend to use the toric lenses and such. Post-operative considerations, again, Jode went through how you do the YAG. You want to avoid that filter zone. There's special online training that you need to take, and I absolutely recommend it. For RK, again, small aperture lenses, it's my go-to. For corneal scars, you can also consider it. And for keratoconus, if there is not significant displacement of the cone and there's no significant apical scarring, you need to look at that topography and tomography and look at the astigmatism, then you can also have success here as well. Again, sutures may be required, especially in those RK patients. If you're using flax with RK, you need to be careful about your capsulotomy removal because of the discontinuities that there can be in the capsule. However, it is still quite easy to remove. And in summary, all patients deserve the opportunity to optimize their vision, even if they have corneal pathology. Thank you.
Thank you very much for a great presentation. Again, any questions from the audience, please come to the microphones. And I'll ask those who are here for the next session to please keep our voices down to allow us to finish this session undisturbed. Thank you.
Thanks. Thanks, Audrey. That was awesome. My question is sort of post-operatively, fundus examinations, and what if they need retina surgery? Is that a big deal when you have the small aperture lens?
As long as they dilate well, the answer is no. And I discussed this with some retina colleagues. You have to make sure the patient can dilate well. If they cannot,
so they can see it from beyond.
Exactly. Yeah. If they don't dilate well, or there's any concerns, like if they have macular pathology preoperatively, that case I showed, then I'm not going to put one of these in. However, if they have a normal macula, they dilate well, then I don't think it's an issue.
I have a question. You mentioned a couple of times avoiding the filter zone, like during implantation. What happens? Why is that?
You can damage it, and you can scratch it, and I guess theoretically one of two things. One, you can damage the lens, but also potentially that pigment, you don't want to release that pigment.
So it's actually pigment impregnation on the surface of the optic.
Correct.
Because you mentioned avoid it during the YAG, but then you mentioned also avoid it touching it during the implantation,
Yes.
centration, et cetera. Okay. It'll come off.
Yeah, it will come off. So you need to avoid it, as Jode said, both during the YAG as well as be careful of it. Don't touch your instruments to it during implantation or during your IA.
Okay, good tips. Anything